As Governor Haslam shared, I'm a partner at McKinsey and Company, which is a management consulting firm probably better known for our work in the private sector, working with many of the leading healthcare companies in the world. But we also do quite a bit of work with governors and with states across education, economic development, technology, et cetera, and are working with a number of states on healthcare, healthcare payment innovation, Medicaid performance improvement, technology, et cetera. So today, my perspectives I'll share will be both from our research as a firm as well as my personal experience working in both the public and the private sector. I should also clarify that we're not a political organization. We're pretty much nerds. And we come at things from an organizational, and operational, and a technical standpoint, but not from a political one. So none of my comments today will be referencing any specific policies or pieces of legislation, including the Affordable Care Act. And in many respects, what I'd like to do is take a step back and actually make a bit of a case for the kind of initiatives that are going on in Tennessee and Vermont. And there's really four things I'd like to share with you today. One is I think we have a unique time and opportunity to fundamentally change the trajectory of the healthcare system in this country, and that's very exciting. I think the next 5 years are going to be critical for the next 25. But those improvements, that change is going to be quite difficult. Second thing I'd share is we think that the performance of each state's healthcare systems could quite likely diverge over the next 3 to 5 years. Some states will be on more of a success path, other states may not. Third, I'd argue that governors and states' actions and inaction will be very consequential, not just in the public sector, but also the private sector. Another way of saying that is I think there's a huge opportunity for what states do and what governors do to encourage, enable, and accelerate private sector innovation. And fourth, I would argue to be on the success path, several shifts are going to be necessary, both from the private sector but as well as the public sector. Shifts in agenda, shifts in capabilities, and shifts in governance. So to start with, and I am a consultant, so I did come with two charts, although two is pretty good. So I won't belabor the point, but despite its many strengths, there's an enormous and well-documented opportunity to improve our healthcare system. There's a number of studies and analyses, including some done by McKinsey that would suggest that hundreds of billions of dollars, we spend hundreds of billions of dollars more than we need to for the outcomes we get. That's true across Medicaid, it's true across Medicare, and it's true across the public sector. In fact, last year I published a paper last year called the $1 Trillion Prize, documenting how intelligent changes in our payment system could literally lead to saving $1 trillion over the next decade. Now, in the face of that opportunity, which I think there's pretty strong consensus for, we're experiencing a number of real discontinuities or massive forces affecting the system, some of which were mentioned. Increasing prevalence of chronic disease, a proliferation of technologies and data, growing provider specialization, increasing role for consumers, and across all of this, an affordability crisis with consumers, with employers, and with taxpayers. So by the way, these forces were all in play prior to the Affordable Care Act. They're all going to be in play regardless of the fate of the Affordable Care Act. If harnessed effectively, I believe these forces present a huge opportunity to capture the opportunity in front of us. However, if ignored or addressed ineffectively, it could actually make things worse. So the challenge is harnessing these forces is actually quite difficult. It won't be easy. There's a great many stakeholders in the healthcare system. It's extremely fragmented. And that brings me to my second perspective, which is that we anticipate even greater separation between states with high-performing health systems and those with less well-performing health systems. Well, why do I say that? Because the innovation that's needed ultimately will play out at a local level. It will depend on the actions and behaviors of literally thousands of physicians, hospitals, mental health professionals, managed care companies, employers, consumers, et cetera. Some stakeholders and communities are going to make change more effectively than others. So allow me to be a bit more specific. I'll just highlight a few areas where I think there's a lot of consensus, not exactly on how to do this, but what the elements of success include. One of those factors on a success path is that there's productive competition amongst stakeholders, both providers and health plans, that encourage greater value. The key here is to ensuring that the competition is actually based on what matters to both consumers, employers, and other purchasers. On a failure path, productive competition is limited because few purchasers or competitors actually understand performance in ways that matter. Second thing, to comments earlier, on a success path, I think healthcare providers will be rewarded for delivering better outcomes at a lower cost. On a failure path, we'll largely continue to pay providers for activity. And last example, I think on a success path, most consumers would have adequate both insurance and savings, agnostic of the approach we use to get there. So the good news is that I think that states or communities that get on and stay on this success path actually have a real opportunity to experience moderated healthcare cost increases more in line with inflation, including in the Medicaid program, will experience greater economic growth and greater productivity and well-being of their citizens. So in other words, I would say being on this success path has a really strong return on investment, to use a business term, both for states directly in terms of their budgets and Medicaid, as well as in a broader societal sense. So if much of the actual change will occur in the private sector, why do I say that governors and state actions will be so consequential? Well, the obvious part of that is that states influence regulation, they influence infrastructure. Those things have a profound effect on how the private sector operates. But what I would call out is the state isn't just a referee in healthcare. It's an actor. And so I think there's a two-way linkage between the actions the state takes as a healthcare participant and the private sector that may be underappreciated. Just as an example, Medicaid spending is in large part a function of the performance of the entire delivery system in a state. It is incredibly difficult for a Medicaid program to sustainably improve from a cost standpoint without the delivery system in that state fundamentally improving its performance. That includes physicians, nursing homes, mental health professionals, et cetera. And it's incredibly difficult, if not impossible, for those providers to change and improve their performance only for Medicaid enrollees. Thus, Medicaid enrollees and private sector enrollees are inextricably linked together from a performance standpoint. So in that way, the two interact. So let's assume you want to be on the success path, right? That sounds a lot better. And let's assume you buy the argument that states can make a positive difference both in public sector programs, but as well as in accelerating private sector innovation. What can you do? A few suggestions here at a high level. The first is, I would argue, to start to measure success based on what you influence as governors and in states, not on what you directly control, and from the perspective of citizens and employers. For example, did employer premiums go up or down last year in your state? Did people get healthier or not? How many healthcare-related bankruptcies were there in your state? Are patients more or less satisfied with their healthcare? Second thing would be to shift focus a bit on enabling and accelerating private sector innovation where most stakeholders agree what's required but needs some help getting over the hump, especially given how fragmented the system is. One of those areas is performance transparency, which is fundamental for productive competition. Another has been mentioned is payment innovation, or leading the transition of all payments from fee-for-service to outcomes-based payment. It includes episode-based payment, capitation, a number of different models. Most healthcare stakeholders, by the way, agree that that's the right direction to travel, but it's really difficult to get done without a critical mass of both payers and providers agreeing on the way to do it, which is why the efforts in Tennessee and Vermont are so terrific. Another area of consensus is that we need better healthcare infrastructure, both human capital and technology. And lastly, I think there's an opportunity to encourage widespread, efficient, and optimal levels of both insurance and savings. The other thing to consider just in the way of doing that is, I think, to consider the influence of the state in healthcare beyond regulation specifically, both as a convener of the private sector and other stakeholders, as well as a purchaser in Medicaid. And so the question there is, both in Medicaid and in providing benefits for employees in a state, are those programs designed and managed in a way to put you on the success path, a way that's neutral to it, or a way that actually causes it to be more difficult? And the last thing I would say is, along with shifting focus and the way you influence things, I think affecting this change will actually require adapting your governance model with even more integration across the various agencies that affect healthcare and its programs. Another way to say that is, who's accountable within each state, in your states, for overall healthcare inflation? Not the Medicaid budget, but overall healthcare inflation. Is there such a person? And lastly, I think you'll need to either develop or partner to get stronger capabilities, both with perhaps a stronger view from a private sector standpoint, as well as people that really understand these models, healthcare technology, and large-scale change, which I think is a pretty different skill set than running and administering a program. And the last thing I'll say just in a few seconds here is a couple very tactical things. Who's on point for this in your administration? Name somebody. Invest a little bit of time learning what's going on. I mean, I think my observation is the last couple of years, there's been more activity and innovation and difference at a state level than there has been for a long time. So I think there's a real opportunity to learn what's working and what's not from other states, more than there has been. I'd say get some real facts on your state, not just on state programs, but the whole healthcare system, and use that to build a real action plan. And the last thing, A number of states are participating in the state innovation model, a number aren't. So I think we agree that can be a really strong catalyst for the type of change that we're talking about. So thank you.
My question is for Mr. Latkovic. You mentioned in your presentation you thought one of the essential first steps toward moving toward quality of care payment based on outcomes versus services performed was a transparent, fact-based measures. And could you give some examples of some fact-based data systems that the public could see?
Sure. It's a great question, and I think there's two things I mentioned. One is simply there's some overall healthcare statistics in a state like premiums or health status, things like that are useful to track. But in terms of what will help actual providers make better decisions or compete on value, or what will help consumers that are trying to make a decision about which healthcare provider to go to, I think the trick is most of the data that's provided today is similar to the way the system is structured today. And so as Bill described, in any, for example, episode of care, let's say you have to get your hip replaced, or it's an elective surgery of some sort, there could be a dozen or more different providers that you interact with over the course of that episode of care. And today, even the data that's released, typically, even if it exists, which most cases it doesn't, but if it does exist, you might get a little glimpse of each of those 10 providers. What you don't get a glimpse of is any sense of, particularly the surgeon that's doing the surgery or the hospital where you do it, how does their performance look in terms of that entire episode of care? So that would be a slightly different way to share transparency. Another example would be, as Andrew described in their model, if you have a primary care physician or primary care team that is historically would just see you in terms of office visits. As a consumer, you actually, you almost have no way to know which of those teams or individual clinicians will do a better job in helping you manage your chronic illness or a worse job. At best, you might get a little bit of fee information on them as individual providers. And so the real trick, again, with the performance transparency is not just the data itself, but however it's accomplished, whether it's private sector or public sector, framing it in a way that's actually usable for consumers, employers, et cetera.
A lot of the focus has been on changing the provider system, moving from a fee-for-service to outcome-based services that rewards quality and outcomes.
My observation, I agree with Andrew. I think it is very different in different communities across the country right now. I think there are certain places that are both culturally, from an infrastructure standpoint, and from a formal sense, the way that the providers aggregate with each other or relate to each other is very, very different community by community. And that's why part of the reason why I think we all agree that there's no single solution that'll work everywhere. It's going to require some differences in local markets.
I would also ask about health risk assessments. We're trying to really incentivize people to do health risk assessments so they know their own risk factors, and then they can work on those.
In many respects, consumer incentives are actually ahead of incentives for the delivery system, where you have, let's assume you have the consumer that's empowered. They have some financial incentives to take care of themselves and their health. The issue is in most parts of the country, the incentives for the providers are actually, in some respects, at odds a bit with the consumer incentive. And at minimum, I would say there isn't an incentive for the provider, be it a physician or a hospital, to actually spend the time to equip the consumer with the information and the guidance that they can use to manage their own health. I mean, specific examples, if someone is at a hospital is being discharged, the hospital in most parts of the country today, many of them do it out of just the general goodness of their hearts, but they're not really compensated to spend time helping that patient understand the medications are on, make sure they're going to go get back with their patients at our medical home or their care team. And so in many respects, what we just need to do is catch up a little bit with the consumer incentive part of it, make sure those two things are aligned.
Really appreciate your presentations. So listening to Gary's comments about Utah, and that's very impressive. Nevada's in a little different position. And we made the decision to opt in with regard to the Affordable Care Act. And we work 49th in the country in uninsured. We're going to be adding 300,000 insured lives within a year. And so that's an immense amount of people that are coming into our healthcare system on a regular basis, many of whom have chronic diseases, about a lot of the things that you've talked about. And as we look, I feel like we can bend the curve with regard to utilization and healthier living, but the place where there's going to be a challenge is bending the curve with regard to healthcare costs. And I'd like to hear kind of your thoughts and observations with regard to those costs, because again, 80% of these lives are going to be in care management or managed care in Nevada. I'm trying to do everything we can to do that. Implement those wellness programs. We're putting these little these bands on to pass those out so people are living healthier. But again, as I look at what we're facing in terms of costs for that, I don't really know what to do. And so I'd like to hear your thoughts.
I'll tell you, that's such an easy question. I'll take it. It's incredibly difficult, right? That is, in some respects, the challenge of the Western world right now, frankly, how to control healthcare costs. I think the truth of the matter is no one really understands the full answer, but I do think a couple of the ingredients there's reasonable consensus on and can be a helpful start. In many respects, the activities that both Andrew and Bill described, as well as in the States, I think are great starting points. I think some of those ingredients include, I think what most people believe is that there's both an opportunity to reduce some of the inefficiencies in the current system, but I think most people also believe that to change the actual rate of growth, it's going to require some more permanent changes, especially in the payment and incentive system, because there's some things you can do in the near term, care management programs, things like that can reduce some of the costs in the near term. But to really get costs to change over time, you both have to change how consumers think and behave. You have to think a little bit of change a bit of the health of the population overall. And then you really need to create long-term incentives for stakeholders, healthcare providers, others, to be inventing new ways to do things better over time. So that really requires, that's a longer-term challenge, but I think that requires not just short-term changes, but kind of permanent changes in how we pay for and reward healthcare.